Hello, everyone. Welcome to our Thursday webinar series. My name is Lourdes. I'm Director of Patient Services with the Cholangiocarcinoma Foundation. I'm glad to have you here with us today. I would like to introduce our speakers for today's webinar. Dr. Trudy Wu is an assistant professor in the Department of Radiation Oncology at UCLA, specializing in the treatment of gastrointestinal malignancies. Dr. Vache Agopian is a professor of surgery and the director of the Liver Cancer Center at UCLA, specializing in liver transplantation and hepatobiliary surgery. And Dr. Richard Finn is a professor of medicine in the Department of Medicine, Division of Hematology Oncology at UCLA, specializing in the treatment of gastrointestinal malignancies. If anyone has questions during the presentation, please put them into the chat and Q&A buttons at the bottom of your screen. And please make sure to make your questions general in nature, as our presenters cannot answer specific questions. Thank you all for being here today.
Thank you. Well, it's really a privilege for us to be here and share with you the liver transplant program that's here at UCLA. And thank you, Lourdes, for the invitation and organizing this. So many of us on this call are, a patient with cholangiocarcinoma, or have had a family member or have a family member diagnosed with cholangiocarcinoma, myself included. And we are all very passionate about improving patient outcomes. But I do think that this should be applied to the broader population. And this is why, because in the year 2040, liver cancer and cholangiocarcinoma is projected to be the third leading cause of cancer-related death. And I really think that, right now is the time for us to invest our resources and our research to really improve patient outcomes for the future, because many of us may know more people who are diagnosed with cholangio. So the NCCN guidelines, they are national guidelines, and they're written up for all different types of cancer. So this is taken from extrahepatic cholangiocarcinoma, which are tumors that arise by the bile ducts outside of the liver. So when is referral to a transplant center outlined in these guidelines? And that is for unresectable disease, meaning that from the upfront, the tumor cannot be removed with surgery. And this encompasses about 40% of patients. So why liver transplant? Well, in the 1960s, the second successful liver transplant indicated for cancer was actually done for an intrahepatic cholangiocarcinoma. And after several decades of outcome data, they found that there are actually high rates of relapse and poor overall survival after transplant alone. So this motivated investigators at University of Nebraska and at the Mayo Clinic to look at doing preoperative therapy before liver transplants. So actually started at the University of Nebraska. They treated patients with brachytherapy, where radiation is directly implanted into the liver tumor, and then these patients receive chemotherapy. And then after that, at the Mayo Clinic, they started with their protocol, which is very different than what University of Nebraska had started with. And in 1993 was when they treated their first patient with the Mayo protocol. So this is the most widely recognized protocol. It's supported by a large series and extensive outcome data. And they included patients with unresectable tumors less than 3 centimeters, which have not spread to the lymph nodes. And the radiation chemotherapy was like this. So patients got 30 radiation treatments. So this is termed fractions. And they were given twice a day. So once in the morning and then once in the evening over the course of 3 weeks. So that's 30 visits to the department for radiation. Each treatment is quite fast, about 15 minutes in the department. And then they get chemotherapy. And then after that, the patients get brachytherapy, where the catheter is directly planted into the tumor. And this is an invasive procedure. After the radiation, the chemotherapy, patients proceed to consolidation chemotherapy. So they remain on chemotherapy until there's a liver available and they get transplanted. This is 10-year data that shows the Mayo protocol. So you can see here, 5 years after transplant, patients, about 70% of patients are still alive. And then at 10 years after transplant, about 60 patients are alive. So this is much better than patients who did not receive any form of preoperative therapy. So do all institutions follow the Mayo protocol? This was a review that was published a few years ago. And the take-home story is that there is variety out there. Some centers are practicing the Mayo protocol. There are different variations where they omit the brachytherapy portion. Maybe they deliver radiation in different fractionation schema. Some places practice with stereotactic body radiation therapy, which is what we do here at UCLA. So here at UCLA, we include patients with unresectable intrahepatic or hilar tumors that are less than 10 centimeters. And our radiation schedule consists of just 5 treatments alone, given every other day. And then after that, patients will get systemic therapy, and they remain on systemic therapy with restaging until a liver is available. So just a little bit of some details about the radiation portion. As I said, we treat with stereotactic body radiation therapy. So if you hear the term SBRT, that's what it means. And basically, this is just higher doses of radiation per individual treatment. So we're really able to deliver these ablative radiation doses. It's very conformal, very targeted. There's very quick dose fall off. So any nearby structures that are nearby the tumor target, there is not a lot of radiation dose that goes to the normal structures. And there is data to support that there's better local control with a higher biologic effective dose, which can be achieved with SBRT. So as you can see here, the patients who have a higher biologic effective dose have better overall survival and local control, meaning that the tumor doesn't grow. So at UCLA, we treat with MRI-guided radiation therapy, and it's really great for upper GI tumors because of the soft tissue delineation that MRI offers. So this is there's a Linac, so the radiation machine uses MRI guidance. So the MRI is kept on the entire time you're receiving radiation treatment. And that's not possible with a conventional CT-guided machine because that exposes patients to extra radiation dose. You can't keep the CT on the entire time. So there are really 2 perks to MRI-guided radiation therapy. The first is real-time target tracking. So as the radiation treatment is going on, you can see the tumor moving up and down, in this case, for tumors that are in the liver. So the radiation beam will only turn on when the tumor target is within a certain gating boundary. And I'll show you a video of that later. The other really big perk of MRI-guided radiation therapy is that we're able to employ adaptive treatments, meaning that the stomach and the bowel, they move around every single day. So if for some reason you forget to fast right before treatment and your stomach is full of food and the stomach is kind of draping over the tumor target, we're able to take an MRI on the day of and replan the radiation treatment to really avoid any changes in daily anatomy. So this is just an illustrative example of how daily anatomy can change. So here on the day of CT simulation scan, you can see the tumor here is in red, and the duodenum, which is outlined in pink, has this much distance. And then on the first day of treatment, you can see that the duodenum is, there's more duodenum near the target. And because of this, you would accept a higher risk of patients being more nauseous, maybe vomiting, and then also causing more toxicity to the bowel. This is what our machine looks like. It's called the Meridian View Ray. The bore, so the hole that you would lay in, it's not as large as it's not as small as a diagnostic MRI. So patients who have issues with claustrophobia usually are able to tolerate this machine fairly well. And the cool thing about the View Ray system is that this is what you would see as the patient laying on the table. So you lay flat, you wear these glasses, and you would see this screen. So this is a MRI cine. It's a view cut lengthwise like this. And the target is the yellow structure. The red is the gating boundary. So every single time, because of where the tumors are, it's right underneath the diaphragm. And with respiratory motion, of course, the target will move. So the radiation beam will only turn on when at least 80% of the yellow tumor target is within the gating boundary, within the red contour. So as you breathe, the tumor will move up and down, and the radiation machine does not turn on. So you don't have to worry about the radiation dose, spilling or going elsewhere to sensitive structures. It's very precise and localized. Just some logistics. We get 2 planning scans, a CT scan, MRI scan. It takes us about 1 week to come up with the radiation plan. And the radiation is 5 treatments every other day. You're booked for about 90-minute appointments to allow for the ability to adapt if necessary. So the first 30 to 40 minutes, you're just laying there on the treatment table. You can listen to some music, and it would be myself and the rest of the team that would be looking at that scan that we get of the day that you're there, to see whether or not we need to recreate the radiation plan depending on what the anatomy looks like. And the recreation of the plan can take, up to an hour, but the actual delivery of the radiation is quite short. It's only about 6 to 7 minutes when you would be laying there, and you would be using deep inspirtors. So you would hold your breath to get that yellow target inside of the red target. From the planning scans to completion radiation, it takes about 2.5 weeks, so 6 outpatient visits total. Most patients, they tolerate radiation very well. Just some common side effects are fatigue and nausea. We do ask that you take Zofran before each treatment. And there's some other uncommon side effects, changes from inflammation, changes in your liver function labs, cholangitis, which may not be a direct side effect of radiation treatment, but just of the inflammation that's caused. And then some rare and late side effects that we do look out for, such as, causing strictures within the bile ducts. And then the other one that we are very mindful of is weakening the wall of the duodenum, which may cause an ulcer or perforation. And those are very, very uncommon, especially with the technology that I just showed you.
Okay, thank you very much, Trudy, and thank you to the Cholangio Foundation for sponsoring this and all you do for our patients. Next slide. So keep in mind, one of the main goals of this whole program to get patients to transplant is to select patients whose tumors are not going to progress and become metastatic, right? The whole point of this program is cure. And we don't use that word often in cancer medicine, especially with bile duct tumors. But the goal here is to take patients whose tumors are not resectable, that are still within a confined space, i.e. the liver or certain part of the liver, and to get them to transplant. Now, for years now, we've known that chemotherapy is of benefit for patients who are not surgical candidates, for example. Definitive chemotherapy does improve outcomes. The backbone for that in the frontline setting has been the use of 2 drugs, gemcitabine and cisplatin. Chemotherapy is not specific to killing cancer cells. That's why we see side effects. The side effects many patients are familiar with, or someone who has received chemotherapy, and certainly nausea and GI toxicity. Some patients lose their hair. We need to watch their blood counts, and some patients become anemic and need transfusions or at risk for infection because their white count goes low. But at the end of the day, this regimen, specifically gemcitabine and cisplatin, is fairly well tolerated on the spectrum of drugs we use. There's been attempts to improve on gemcitabine and platinum with various chemotherapy agents, developing triplets or comparing other regimens versus that. And really, it's only in the past few years that we've been able to improve on Gem-Cis in the frontline setting, meaning the first line setting. Now, Dr. Wu alluded to the Mayo Clinic protocol, which was actually developed even before gemcitabine and cisplatin was used in bile duct cancers. And in that context, 5-FU, an older chemotherapy drug, was used. And we have adapted it now to include the most up-to-date regimens we can, with the goal, in the context of a transplant, to control a patient's tumor until they get a transplant. And again, for patients who are not being treated in the context of a transplant protocol, chemotherapy, targeted therapy, immunotherapy has all been shown to help people do better. And if frontline chemotherapy doesn't work, regimens such as FOLFIRINOX and others have been shown to work at progression. But still, there's unmet needs in bile duct cancer, and we're constantly working to do better. Next slide. So in the past 2-3 years, we've seen the results of 2 phase 3 studies, so definitive studies that added immunotherapy to gemcitabine or cisplatin. There were 2 studies that have been published and led to global regulatory approvals. One, the Topaz-1, which looked at a monoclonal antibody called durvalumab, and the Keynote 966 trial, which looked at pembrolizumab. As far as disclosure, these studies were sponsored by AstraZeneca and Merck, and I consult for both of these companies. Both of them yielded very similar results and have become 2 frontline options. And we'll show that really both these regimens perform very similarly in their management of patients with advanced bile duct cancers. And we have adapted this to use this as the backbone for patients while awaiting a liver transplant. Next slide. So here you see the results from the Topaz study with durvalumab. The primary endpoint in all these studies is to help people live longer, and we call that overall survival. Now, there are other endpoints we look at in clinical studies and of various importance, one of them being progression-free survival, which is the time it takes a patient's tumor to grow beyond certain criteria from the start. And progression-free survival also includes how long not only patients progress or if they pass from their disease. So in the Topaz study, this was a positive study. And let's be honest, this is a very modest benefit, right? Survival with gemcitabine and platinum for this general population was 11.5 months, and that improved to 12.8 months. Progression-free survival went from 5.7 months to 7.2 months. And if we look at the objective response rate, which means the tumor burden shrunk by 30% from baseline, so that's 30% is a very specific criteria. If someone's tumor shrunk by 25%, that would not be counted as an objective response, but could be clinically meaningful. And you can see that with durvalumab, gemcitabine, and cisplatin, the objective response was just under 27%. An important number or metric we look at in clinical trials is something called the hazard ratio. And that is really risk reduction. And it shows here that the hazard ratio for the overall survival is 0.8. So that means a 20% decrease in the risk of death for patients on the study. Now, these are statistics, and I know it's very, very sobering statistics at the end of the day. But for any given patient, we don't know. You know, certainly you can see at the tail of this curve in red, there are patients who do better than others. We just are talking about medians here. And for any given patient, you know, we can't predict whether they're going to be one of the very long, disease control patients or not. And also keep in mind, in the context of our conference call today, the goal is to get them to transplant and to control their tumor for as long as possible. Because if the tumor grows beyond transplant criteria or spreads out of the liver, that will take them off the transplant list. And given, and Dr. Rogopian will talk about this, given that it takes a while to get a liver transplant, we want to control their tumor while waiting that time. So this is the result of the Topaz study. Next slide. Here is the Keynote 966 study, a very similar study. Both these studies randomly gave patients chemotherapy with placebo or chemotherapy with one of the immunotherapies. And in this study, patients got pembrolizumab. You can see at the median overall survival, very similar results, 10.9 months to 12.7 months. And you'll remember with durvalumab, it was 12.5 months. So very similar results. And you can see here the hazard ratio of 0.83, very similar to the hazard ratio of 0.80. Now, in this study, we did not see an improvement in progression-free survival. There was about a month difference, but that did not reach statistical significance. And you can see here the objective response rate was 29%, very similar to the objective response rate we saw with durvalumab. But interestingly, in this study, the control arm of chemotherapy also gave a very high response rate of about 29%, higher than the 18% we expected. What was different with pembrolizumab is that there was a longer duration of response. Those who responded, it tended to last longer than those who responded with chemotherapy alone. It's important to note, and this is some nuance and more, I think, to be aware of, is how long patients receive treatment in both these studies is a little different. In both studies, patients received cisplatin for up to 8 cycles, whereas in the Topaz, patients completely stopped both chemotherapy drugs at that time. And in Keynote 966, per the investigator and the patient's discretion, they could continue the gemcitabine for longer. In my practice, again, if patients are tolerating things and the tumor is controlled, I tend to continue chemotherapy a little longer than as done in the protocol. Is that beneficial to the patient? I think it's a little unclear. I don't want to hurt patients, so that's why it's an ongoing discussion. But for many of us, if a tumor is responding and controlled, if it's not broken, why fix it? Is one of my mantras in medical oncology. And broken can be just too much side effects, and that would be a reason to change. Next slide. So both these drugs are immunotherapy. Immunotherapy is talked a lot about in the lay news as well in the scientific literature, and there's no way to underestimate the impact these drugs have had in cancer medicine. I think all of us at UCLA are very proud of the contributions made to the immunotherapy space. My colleague in medical oncology, Tony Rebus, really led the development of these drugs in melanoma and then in lung cancer. Eddie Guerin, I've been very blessed to play a role in the development of these drugs in liver cancer, HCC, as well as bile duct cancers. And what we know is that these drugs work on exposing the tumor to the immune system. So, one of the fundamental concepts in cancer is, why doesn't the immune system attack cancer cells, right? Why can't our immune system, attack cancer cells and therefore eliminate cancer? Well, one thing is, cancer is self. It originates in our own cells, so our body doesn't naturally attack itself. But we do know that cancers, because they're unstable, can make new proteins, or proteins the immune system hasn't seen for a long time, and therefore the immune system should attack these cancers. However, cancer is smart, and it has a way of escaping from the immune system, and one of those escape mechanisms is to engage this protein PD-1. And PD-1 is a protein that interacts with the immune system and essentially tells the immune system, don't attack me. For those of you who ever watched Star Trek back in the day, the Klingons had something called a cloaking device, right? It made them invisible to Captain Kirk. And similarly, tumor cells can cloak themselves and block themselves from the immune system. Now, it was discovered, and James Allison and colleagues won the Nobel Prize a few years back for identifying the importance of this protein interaction. And now we have drugs that interrupt this. So there's many drugs. For example, you see here listed pembrolizumab, that is a monoclonal antibody, so an antibody designed to block the interaction between PD-1 and PD-L1. And similarly, there's drugs like durvalumab, which was used in the Topaz study, which also blocks this interaction. Some of them block the receptor, some of them block the protein, but at the end of the day, they're designed to work very similarly, and that is to allow the immune system to see cancer, to attack it. And while these drugs by themselves have never really shown a lot of activity in bile duct cancers, there seems to be some synergy when they're combined with chemotherapy. And that was the rationale behind the 2 studies we just reviewed, and why they are both right now approved for the treatment of bile duct cancers. Next slide. So here we see how chemotherapy and these drugs are given. Uh, you know, in in practice, a patient would come to the infusion center. This is a place where we have trained nurses who are trained to give chemotherapy. Often, these are very comfortable spaces, relaxing spaces to make it as stress-free as reasonable. Uh, Patients will generally get an IV placed, and on their first day, they will get 3 treatments. They will get gemcitabine, cisplatin, and the immunotherapy drug. Often patients get pre-medicated with drugs to manage side effects such as nausea. We'll check their blood counts. Often you'll be seen by your doctor or a nurse practitioner. And then you will go home. The IV is taken out. An infusion, depending on, timing, probably would be about 2.5 to 3 hours on this day. And then you'll be home for the week. You'll come back for what we call day 8. And on that day, you'll get the chemotherapy alone. So it will be a little shorter day. And then you have a week off. That's called week 3. And that allows you to recover from the side effects of chemotherapy. Now, a few nuanced things to know. Certainly, side effects in cycle 1 are less than on cycle 8, right? There is some cumulative side effects we see with chemotherapy, and this requires us to make adjustments. This could be in the dosing, the frequency of the drugs. The way I like to explain it to patients is it's like taking a flight. There might be turbulence, and so your pilot needs to make adjustments so you hit smooth air. And sometimes that takes some time, and it takes you discussing your side effects, your concerns with your physician and caretakers, and making appropriate adjustments so eventually have some smooth air and this is not too toxic. One other thing I would mention, and different clinicians do this differently, is some patients will need a port. A portacath is a way for us to deliver chemotherapy into the body instead of just a peripheral IV, the type of IV that a nurse will place and take out on the same day. Sometimes, because a patient's veins might be weak or it's hard to get an IV and it might take several pokes, which is uncomfortable, a port is a device that sits under the skin. Typically, it's placed by interventional radiology, and it takes maybe a 45-minute procedure, and it allows the nurses, when you come to the office, to place an access device in there, draw blood with one stick, give you your infusions with one stick, and when you come home, they take the port out, or the needle out of the port, and you can go home and shower, and it's protected under the skin. But the whole idea with this treatment, again, is to control your tumor to get you to Dr. Agopian for transplant. Next slide. So in closing, I think we just want to go over the side effects, and I alluded to some of these, and this list is not exhaustive, but these are the most common things. Many of these things we can manage with supportive treatments. Some are harder, to be honest. Fatigue is something that's very hard for us to manage. There's no quick intervention. There's no medication that quickly fixes fatigue, unlike things we have for blood counts or nausea. We watch your kidney function and liver function and lab work on a regular basis. And a key thing to be aware about with immunotherapy often has very few side effects. Unlike chemotherapy, which almost everybody has some side effect to some degree, some patients with immunotherapy have no problems. And some things are common. We can often see a rash or thyroid problems, which again are not very challenging to manage. But occasionally we can see autoimmune events. And really, from activating the immune system to attack cancer, sometimes the immune system can get a little excited and attack areas we don't want. And essentially, we can see any type of itis. Any organ can get inflammation to various degrees. And in severe cases, we might need to use steroids to turn off the immune system or other drugs. And that is something we watch for. And some things are more common, like I said, rash or thyroid issues, but then again, we can see serious side effects. And as I transition to Dr. Agopian, the one thing that the team will think about, because as Dr. Wu alluded to, historically, the chemotherapy we used did not include immunotherapy. And immunotherapy at around the time of transplant can be a little tricky because with transplant, you want to turn off the immune system so the new liver gets accepted. And at the same time, we're using drugs that activate the immune system. And I think we now have a pretty good sense that immunotherapy can be used cautiously around the time of transplant, depending on a patient's timing of transplant. Sometimes we would stop the immunotherapy beforehand. But this is something your individual doctor will manage. And one last thing I'll mention, because it's topical, targeted therapies are now being used in bile duct cancer. You've heard about FGFR2 alterations, HER2 expression, BRAF or IDH. And these are also options in the pre-transplant setting, especially if chemotherapy or immunotherapy can't be used, or if there's side effects, or if patients' tumors grow a little bit on these treatments, then certainly those targeted therapies would be considered. So with that, I'll transition to my friend and colleague, Dr. Agopian.
All right, great. Thanks, Dr. Wu, Dr. Finn, and to the Cholangiocarcinoma Foundation. It's really a pleasure to be here. And I'm going to speak about liver transplant and everything about it and show some data. Next slide. So I think it's important to just take a step back and really talk about the anatomical classification of cholangiocarcinomas. We've kind of spoken about it in one kind of as if it's one entity, but the reality is that it's different diseases, right? So the most common, hit the next button, please, is hilar cholangiocarcinoma, or what's known as the Klatskin's tumors. And these are the tumors that arise in the main bile duct right before it bifurcates into the left and right duct and goes into the liver. And in the inset over there, you can see the bismuth classification. I'm not going to bore everyone with the details, but actually the vast majority of hilar cholangiocarcinomas, if caught early, actually can be resected. So it involves removing the extrahepatic bile duct and removing either the left or the right liver. So when liver transplant comes in, is really in these type 4 cholangiocarcinomas where the tumor is going both into the left and into the right side. And so there's no reasonable way to remove all of it and leave liver behind. Or I will say, in patients who have, for example, primary sclerosing cholangitis and underlying liver disease or cirrhosis, in that setting, again, it's more ideal to fix the entire liver as opposed to trying to cut out the cancer. So clearly there's a role for liver transplantation in hilar cholangiocarcinoma. Next. Conversely, the intrahepatic cholangiocarcinomas it is a different disease. It arises from the bile duct epithelium within the liver, but the vast majority of patients that require a liver transplant in the setting of intrahepatic cholangiocarcinoma really have underlying liver disease and cirrhosis that really limits our ability to do a resection to remove it. Or more lately, we're seeing data, even in patients with non-cirrhotic livers, patients that have really large tumors or multifocal tumors where, again, you can't reasonably get all of it out. There is a setting in select patients to offer liver transplantation. Next. I think it's important to know that the strongest data supporting the role of liver transplantation is in hilar and Klatskin's cholangiocarcinomas, and particularly those meeting the Mayo criteria. We heard about this from Dr. Wu. The Mayo criteria basically states that the tumor can't be greater than 3 centimeters in size, and we do a series of testings to make sure that it's not spread to the local lymph nodes. But this was a large multi-center study published a number of years ago, 287 patients with hilar cholangiocarcinoma, and you can see those patients who had tumors within the Mayo criteria had an excellent 5-year recurrence-free survival of nearly 70% following transplant. Conversely, those patients who had larger tumors and that were outside the Mayo criteria had lower recurrence-free survival at 5 years. And it's really on the basis of data such as this that liver transplantation has clearly been accepted as the gold standard for patients with unresectable hilar tumors that are less than 3 centimeters. Next slide. But I will say in the last decade or so, there's emerging data for a role of liver transplantation in patients with intrahepatic cholangiocarcinoma. Again, a little bit of a different disease. This was one of the early international multicenter studies. We contributed patients to the study published by Gonzalez Apisogin a number of years ago. And basically what they found in this study was patients clearly in the setting of cirrhosis, because you wouldn't need to transplant somebody with a tumor less than 2 centimeters, but clearly in the setting of cirrhosis, that if you have a small tumor, you do better. You have a lower recurrence rate, and you have improved overall survival compared to patients who had either advanced tumors, large tumors, or multiple tumors in this study. Next slide. I will say that it's really hard to diagnose tumors when they're 2 centimeters or less, especially in the setting of cirrhosis. Sometimes we think that those are hepatocellular carcinomas or a different kind of carcinoma. So it's nice that we've seen in the last number of years that for patients with intrahepatic cholangios that are larger, that there is, again, seemingly a role for liver transplantation. So this was a French multi-center study, and they took all cirrhotic patients. It was 45 patients, again, relatively small numbers compared to the chemo trials, et cetera, but 45 patients with cirrhosis. All of them had tumors in this 2 to 5 centimeter range. And what they did was they compared the outcomes of the 24 patients that had liver transplant compared to the patients that had liver resection. And the overall survival was the same, but not surprisingly, actually, patients that had liver transplant with an intrahepatic cholangio in the setting of cirrhosis had improved recurrence-free survival. And we can surmise that this is because we're not only removing the tumor, but we're fixing the underlying liver disease, the cirrhosis, that really is what drives new tumor formation. Next slide. And I would say probably what's most provocative and really potentially not widely accepted yet, but nonetheless something to think about is basically based on the Houston Methodist data. This was a small single center prospective study, and they took patients with unresectable intrahepatic cholangiocarcinoma with the fact that there was no upfront size or number restrictions. Many of these patients had large tumors, multifocal tumors, but the key in this study was that all the patients were treated with 6 months of systemic chemotherapy, and they had to demonstrate a favorable radiographic response. So that means their tumors shrunk, or at the very least did not grow, and no new tumors showed up, and that they had to have a good biomarker response. So one of the common serum tumor markers we follow with cholangiocarcinoma is CA19-9, and they would have to demonstrate that that serum tumor marker is decreasing. And for patients that met those criteria and made it to transplant, you can see really an excellent overall survival of 79.5% at 5 years, nearly 80%. Now, I will say that half the patients did develop a recurrence. A lot of times these recurrences were solitary, maybe a lung lesion, they were treatable, but nonetheless, the survival was much better than if we couldn't transplant these patients. Next slide. I think there's also data clearly showing that the center experience matters for liver transplant. This was a study published a number of years ago showing that patients getting a liver transplant in the setting of cholangiocarcinoma at high volume centers had better survival than patients receiving transplant at low volume centers. Next slide. And several years ago, we updated our own experience. We have a 3-decade experience of transplanting patients with cholangiocarcinoma, and this was a cohort of 53 patients, about 30 or so intrahepatics, 22 hilar cholangiocarcinomas. And the key takeaway that we learned from this study was that patients that received both upfront systemic chemotherapy as well as some local therapy. So for the hilars, they received radiation-based therapy. For intrahepatic tumors, they could have received, again, radiation-based therapy or other local regional therapies. But if you received both, your long-term outcomes were outstanding. And I think many centers that transplant patients with either hilar or intrahepatic cholangiocarcinomas now obviously have adopted this kind of protocol where you're treating patients with chemo and some local regional therapy to keep the tumor, like Dr. Finn said, under control until we can hopefully get you the liver transplant. Next slide. So at UCLA, obviously, we're a very experienced transplant center. We've done more than 7,000 transplants since 1984. I just show this picture here. This is Dr. Ron Busutil, who's really one of the pioneers of liver transplantation, founded the program in 1984, and really all the transplant surgeons that work here have been trained under him. He recently retired a number of years ago. Notably, we've done more than 1,200 transplants for patients with oncologic indications. Now, of course, admittedly, the vast majority of these patients have hepatocellular carcinoma, which is much more common, but we're now up to close to 60 patients with cholangiocarcinoma that we've transplanted, a lot of these in the last decade or so. We've done more than 100 living donor transplants. We average 150 to 175 adult transplants per year. We have a large active wait list of adults and children, and we have taken on some of the complex cases in the country. We've had several cases where you'd have to do a liver transplant along with a Whipple because the very end of the bile duct we couldn't clear. I mean, these complex cases that, again, we don't typically do, but the only reason we can address and take on some of these cases is really our multidisciplinary team, right? We have a large team, transplant surgeons, hepatologists, medical oncologists, the nurses, the coordinators, managers, all these people that really help guide the patients through the process. So next slide. So how does this work? So you have a cholangiocarcinoma, you get referred to our program. So really the first step is a comprehensive evaluation, and this includes an assessment of one's general health and their operative risk, and of course, the extent of their tumor. Typically, a candidate meets with the surgeons, hepatologists, oncologists, social workers all in one day, and then they undergo extensive cardiopulmonary testing. And once completed, transplant selection committee will review the case, and there's several there's several outcomes that come out of the committee meetings. Sometimes we actually say that a patient is early. What does that mean? Well, we reviewed the studies and we say, this patient we actually think may be resectable. There's no reason to get them to transplant because we can remove the tumor. And this is we've done this just twice in the last month, where again it was thought to be unresectable and we felt otherwise. A lot of times when some more testing may happen, occasionally, unfortunately, patients can be declined for transplant for several reasons. Their tumor burden is beyond acceptable criteria, or they've developed evidence of extrahepatic disease, as Dr. Finn alluded to. In those cases, we don't help you with a transplant, actually. We probably hurt you with a transplant if the disease is spread outside the liver. And then occasionally there's medical comorbidities or other barriers to transplant. Now, once you're accepted and you're listed, next slide, a patient needs to be assigned a MELD score. We're going to take a moment here to talk about this. So the MELD score essentially is a reflection of how sick one's underlying liver disease is, and it's what's used to guide allocation of organs in the United States. But again, this is meant for people with liver failure, not necessarily people with liver cancer like cholangiocarcinoma or hepatocellular carcinoma. And the key over here is that many of our patients with cholangiocarcinoma actually have very well-preserved liver function, so their calculated MELD scores actually don't reflect their medical urgency in getting a liver transplant. And so because the MELD is what allocates organs to patients, if you were listed as a cholangiocarcinoma patient with your own physiologic MELD score, you probably would never get an offer from the cadaveric donor pool because your MELD score would be very low. So in these situations, we have to apply on your behalf an application to UNOS to get what's called a MELD exception score. And what that is, it gives you extra points that then at least attempts to estimate your risk of waitlist dropout or falling off the risk so that at least you can compete for some cadaveric organs. And I will say that up until very recently, only patients with hilar cholangiocarcinomas meeting the strict Mayo criteria qualified for automatic MELD exception points, but there's been a lot of advocating for this on the behalf of patients and doctors and transplant professionals, and now UNOS has approved a standard MELD exception point for patients with intrahepatic cholangios. We were never able to get points for these patients with intrahepatic cholangios, at least automatic points for up to 3 centimeters, and then on a case-by-case basis, we've definitely gotten points for our patients with larger tumors that have demonstrated, again, good responses to therapy on the list. Next slide. Now, once you're on the wait list, the waiting time can obviously range from days to weeks to even months and even years, and many, many things factor into this. Your blood type, your height, your weight, the operative complexity, the geography that you're in, and organ availability. I will say that at UCLA, we essentially explore all options to reduce waiting time. At times, we'll advocate for multiple listings in different centers in different geographies. Sometimes you get a liver somewhere else quicker, sometimes with us more quickly. And we're also aggressive in expanding the donor options. Of course, the standard donor livers, but we're also very aggressive utilizing what have traditionally been known as these extended criteria donors, donation after circulatory death, actually use of hepatitis C or hepatitis B positive donors, because those organs can work just fine and we can treat the infections in the post-transplant setting. And I would say in the last 2 years, one of the greatest changes in transplantation has been the onboarding of machine perfusion technology. So what that is when the donor organ is removed from the body, we typically have only so much time if it's sitting on ice to implant that. And so there's only so far you can go to get an organ, etc. But with machine perfusion, the organ is perfused with warm blood that's oxygenated. So the liver's sitting on a machine and doesn't even feel as if it's been removed from the donor's body. And this has really allowed us to utilize all sorts of organs that wouldn't have been suitable for transplant, but we can actually watch their function on the machine and make, educated decisions about utilization of those organs for our patients. And so it's really been helpful, especially for oncologic patients. So obviously, if you're on the list, you got to be available 24/7. We never know when an organ offer will come. Next slide. And when you get the call, you come into the hospital, you get prepped for surgery. I will say the surgery can be anywhere from 6 to sometimes 8 to 10 hours. I will say the hilar cholangiocarcinoma patients, even more so than the intrahepatics, they can be challenging because a lot of times they've had radiation to the porta hepatis, which is where all the important structures are that we need to preserve. So sometimes it takes a little longer to get those livers out, but most patients do just fine. What are the risks after transplant? Well, like with any operation, you can have bleeding complications. Any of the, I always say I'm a plumber. We're doing a plumbing operation. We're connecting all sorts of, blood vessels together and bile ducts together. And so any of those can obviously potentially have a problem. That's relatively rare that we have those kinds of issues. The length of one's hospital stay really depends on their medical needs. But I would say for healthy patients coming in from home with cholangiocarcinoma, I would say on average, they stay in the hospital 10 to 14 days, during which time we're working with physical therapy, occupational therapy, a lot of teaching about the lifelong immunosuppressants that you're going to have to take to prevent rejection. And of course, once you're discharged, you have very, very close follow-up. You see the surgeons weekly for the first month, and then the hepatologist biweekly, really indefinitely thereafter to make sure the liver's functioning well. Next slide. And I will say that it's not uncommon to be re-hospitalized for some complication after transplant, at least once during that first year. Well, some of the more common complications are immunologic rejection. About a fifth of transplant recipients will have at least one episode of rejection. But honestly, if caught early, it's very readily treatable by adjusting the immunosuppression medications. Infection is increased risk. Obviously, again, these patients are immunosuppressed, so they'll develop pneumonias or urinary tract infections, but again, relatively readily addressable. I will say that the quality of life of these transplant patients are really overall excellent. Next slide. And we have a large, great multidisciplinary team here to support you and get you through your journey. Next slide. So what is this is I want to give Dr. Wu credit for this. This is a very nice slide, but I'll summarize here. What is our hope for our cancer patients, our cholangiocarcinoma patients? Well, first, a convenient high-dose targeted radiation treatment using advanced technology that you saw to stop the tumor growth while awaiting an organ. Okay, then we leverage the 3-drug combination, chemotherapy along with immunotherapy, to treat the primary tumor and just prevent the cancer cells from spreading to other parts of the liver and body, again, while awaiting an organ offer. And then finally, we obviously hope this for everybody. We receive the call that we have an organ offer for our patient. They undergo a liver transplant with the support of the expert team that we've spoken about, and they become a long-term survival of cholangiocarcinoma. And there's very many patients we have that have had this outcome, and obviously we hope this for everybody. So with that, I'm going to stop, and I think as a team, we're very happy to take any questions.
Thank you all so very much. If anyone has any questions, please put it into the chat or the Q&A. I know that there was a question from someone asking if international patients are accepted by UCLA. And maybe I know Dr. Finn mentioned yes, but if you can maybe go into a little bit more of what international patients might have to do differently in order to get to your center.
I'll let you take that, Vache.
Yeah, no, we have a whole international office to help facilitate this. I mean, obviously, the real challenge with international patients is it's the financial arrangement. It's the financial arrangement because you don't typically have medical insurance in the United States, and so that needs to be sorted out. And obviously, and that's a hospital level thing, but it's a well-oiled machine. These are things that our hospital administration, the financial counselors all discuss. We have many international patients coming from Asia and the Middle East, et cetera, and we do this relatively frequently.
Can you talk a little bit more about your thoughts on living donors for transplant?
Yeah, no, absolutely. So living donors is a great option for patients with cancer. Now, I will say that in our program, we have traditionally done I put that in a slide. It was about 100 living donors, many adult to adults for cancer. I will say when the MELD system came on, we were just such a busy program. We're getting so many organs cadaverically that the decision was just made programmatically that we're not going to pursue living donor very aggressively. Now, I will say that the living donor is an option in very many centers, but especially with machine perfusion technology, even the centers that are doing living donors, like we're able to get organs that we weren't otherwise able to use. And so for us, we're just getting our living donor program going again, but I don't foresee that as the main source of getting our cancer patients transplanted. I do think it's an important important option. Not every patient has that option, and certainly we certainly support that. If a patient has a living donor, and that's something that we certainly can pursue.
So I see this tumor, this question here. If the tumor started at 12 centimeters and the chemo and maybe radiation shrunk it down to 5 centimeters, does it make them qualify? Because in New Zealand, we got told we will never be able to be qualified because the base is the size at the beginning. I think this is someone we would entertain. You know, I think one of the main issues here is not just the size, but is it a solitary lesion confined to the liver that's well controlled? You know, we can't predict a tumor biology when we first meet someone. You know, certainly you'd say, oh, 12-centimeter tumor, that's an aggressive tumor. But now, months later, we see it shrunk. Certainly, we would consider listing someone like that. You know, how their score would work out, that's a challenge. And Dr. Agopian alluded to that, you know, liver transplants are given out based on the MELD score. And there's two ways you get a high MELD score. Your liver is very sick because it's based on the lab values, bilirubin, creatinine, and INR. And the higher the MELD score, the sicker the patient is, and the more urgently they need a liver transplant. Now, a lot of patients with bile duct cancer might have some liver dysfunction, but their MELD score might not be high. For example, in our region, the average MELD score at transplant is like 33, 35 points, somewhere in there. So there's a mechanism where we can appeal to get patients extra points. It's called an exception, and in the future, UNOS, the organ distribution network, will automatically give points if it's a solitary lesion less than 3 centimeters. In this case, we would have to appeal to get extra points for this patient. We could certainly list them for a transplant, but unless they go into liver failure, it'll be very hard to get them a transplant without getting them some bonus points. Or for that matter, this might be a good patient for a living donor, right? Because the tumor is controlled and maybe a mechanism. So I'll leave it like that.
Yeah.
I don't know if anyone else wants to add. I see a patient.
Yeah, no, I mean, the only thing I was going to add is that I think it's important to also discriminate between standard exception points where we don't, it's automatic, and you make an appeal to so there's a National Liver Review Board, and there's going to be a transplant oncology specific National Liver Review Board. And we've done this for many of our patients where you actually, on a case-by-case basis, you make an argument as to why this patient, who was, yes, beyond initial acceptable criteria, has demonstrated certain things over the course of their treatment that would make them a good candidate. And I would say we've had many patients that were able to successfully get exception points on the basis of this kind of an appeal. But that's a case-by-case basis. So to answer the question specifically, yes, kind of you wouldn't like reflexively get exception points for somebody who started with a 12-centimeter tumor, but it's possible, obviously, that you can appeal and get points for them. And we've had successfully argued for that in many patients.
Thank you. For Dr. Wu, instead of the moving target, why can't the patient just hold their breath?
Yeah, so the radiation is actually given while you're holding your breath, but even with breath hold, there's variation. So depending on the degree of breath hold, you will see, you'll try to, adjust. And as the treatments go on, you'll become more familiar with the different techniques, but it is treated in breath hold.
Okay, thank you.
I see a comment from Vincent DeMauro, who's a real person, not a paid advertiser for UCLA Health. Thank you, Vincent.
How do you check the main bile duct when taking the liver out for intrahepatic cholangiocarcinoma? How do you make sure all the cancer is gone?
Yeah. So for intrahepatic cholangiocarcinoma, technically speaking, you're not removing the extrahepatic bile duct, right? So there's no reason to remove the extrahepatic bile duct. But what we do in that case is we intraoperatively will send a frozen section. So we remove the tumor. Sometimes grossly, you can cut into it and kind of just see how far the tumor is. But we send it to the pathologist to kind of get a quick and dirty what's called a frozen section. That's not the final pathology, but it's a good enough answer to give the surgeon confidence that there's no tumor at the margin. Similarly, for hilar cholangios, where we are removing the extrahepatic bile duct and part of the liver, we usually will cut as far down as we need to, and again, send that little slice and make sure that the pathologist looks at that slice and says there's no evidence of any dysplasia or cancer or anything like that. And once we get that, then we know we don't have to go any farther in terms of resecting more tissue.
Someone is asking, do your intrahepatic cholangiocarcinoma bile ducts grow back?
No.
Yeah, and it's not really an important question. No one will take you to surgery unless your liver is ready to go at time 0. Once the liver is cut out or a piece is cut out, you need a new liver, or your liver needs to be strong enough to maintain itself. And, that's all calculated beforehand. The liver, if you have a resection, the remnant liver will grow over time, and patients are often curious about that. But at the end of the day, it's not that important as long as you're working, at time 0.
Okay. Another question about living donors. How does that anatomically work? How much and what part of a liver is used or replaced? Is this consistent with someone with PSA? Can it cure that disease?
PSC?
Maybe they were meaning PSC.
Yeah. So this is a really, actually, it's a very good question. So probably hard for me to answer it in a short period of time without drawing diagrams. But a living donor is essentially a piece of somebody else's liver. So you have to leave the donor with enough liver that's good for them. And why it's challenging, of course, living donor is done for cholangiocarcinomas, but why this is challenging in particular is because the donor liver, the piece of the donor liver does not come with vena cava. Again, I wish I could draw this for everyone, and I'd be happy to. But so you have to make sure that in removing the diseased liver of the recipient that has the cholangiocarcinoma, that you're not leaving cancer cells behind. And many times with hilar cholangio in particular, the caudate lobe, it's a specific part of the liver that's really wrapped around the vena cava. Ideally, we could remove that whole area with the vena cava. That's why in an ideal circumstance, we have a cadaveric donor that comes with the entire vena cava and just not a piece of the liver. When you have to save the recipient, the patient who needs the transplant, when you have to save a piece of their vena cava, it does risk a little bit. Are you completely cleaning out that area along the vena cava that may be involved with the cancer? So that's a case-by-case decision. And sometimes you will see at a living donor evaluation, you might look at the recipient's tumor and where it is and just say, this is not going to be a candidate for a living donor. We need a whole graft because we don't think we can get the whole tumor out by trying to save their own vena cava, because a partial graft does not come with a vena cava. So I don't know if that, hopefully that answers the question, but it really is a case-by-case basis about who would be a good candidate for a living donor based on where their tumor is.
Okay, perfect. Thank you. If one is stable with systemic treatment and hasn't had liver-directed treatment and are currently listed for transplant, is there good outcomes, or should they get some liver-directed radiation first?
To be listed, and part of our protocol is that you include radiation.
Yeah.
So it's an interesting question. We've had patients who we didn't really initially think about transplant. They're doing well on medical treatment, and we say, well, maybe they should be listed, and we will go back and radiate them at that time.
Yeah. And the outcomes, we showed that too, right? I mean, even with our own center outcomes, we showed that the patients that can receive both had the best post-transplant outcomes. So when feasible, that's what we try to do.
Okay. What if the original tumor was resected and came back, but is not growing since immunotherapy has been started? Would that potentially be a liver transplant candidate?
I think it depends on where it comes back. That's the most important. So if you have a hilar cholangio, which is technically speaking outside the liver, and you cut it and you had a recurrence, the question is, where is the recurrence? Is it along where it was cut out? Do we think it's just a local recurrence and the whole thing wasn't removed? And maybe you can say, okay, fine, it wasn't just completely resected, and we can still keep it in that area and we can remove it. But if it was a hilar tumor, for example, and the bile duct was cut out, and then you just had a completely separate lesion in the liver, completely away from where the original tumor was, then the concern would be, well, maybe that's metastatic disease, right? Maybe that's not just that it came back in a metastatic fashion. And so then you would have a much higher bar. I mean, those are patients that would be difficult, I think, to think about. So it really depends on where and in what fashion the tumor came back, and whether or not the assessment is that this is a local recurrence, meaning maybe some cells were left behind in the area where the original tumor was, versus the cells have already spread somewhere else, landed somewhere else, and growing somewhere else, in which case I think it's a tougher problem.
How many lesions in the liver is acceptable for liver transplant?
Yeah, we spoke about this a little bit. I think that the what's acceptable for the community at large are hilars meeting the Mayo criteria, and now intrahepatics up to 3 centimeters. And of course, we have many patients with larger tumors and multifocal tumors. I think in that setting, so those are patients. So if you start out with a 9-centimeter tumor, or you start out with 4 intrahepatic cholangios, you're probably not going to get standard MELD exception points. But again, as the Houston Methodist protocol showed, and they continue to do that, and many centers do this, I think then we use other surrogates. What is your response to treatment? You get on treatment, you have some test of time that shows that you don't have evidence of lymph node spread, your tumor markers come down. So the longer you do well on a list, the more likely it is that you're going to benefit from transplant. I think one of the most difficult discussions with patients is they want the transplant yesterday. And what I have this discussion many times, and I say sometimes, especially if your liver is working, if you have a functional liver, you don't need somebody else's liver. And the last thing we want to do is transplant you too soon without having an opportunity to observe the biology of the tumor, right? Because if that tumor has microscopically spread outside the liver, we actually hurt you with immunosuppression. We actually hurt you. We don't help you. So I think that with these more advanced tumors or multifocal tumors, I think the longer that they demonstrate that it's stable staying in the liver, the more confidence that we have that we can actually potentially cure them with a liver transplant.
Can living donors be used for hilar tumors?
Yep, same discussion as before. I will say it would have to be case by case basis. In an ideal setting, you have a whole cadaveric graft, but of course, living donors are used all the time. The complexity of the operation is much, much more, because then you have to you just have to do a lot of reconstructive plumbing work, because the partial graft that you're getting is not coming with all the blood vessels that a whole liver would come with, but it's certainly possible.
Okay, perfect. Do siblings provide a better outcome for living donors, in your opinion or your experience?
For livers, that's the beauty of the liver. It's a very immunotolerant organ. I think all we care about is blood type matching. That's all we care about. It's not like kidneys. We don't look at the haplotype. We don't look at any of those things. We just same blood type, compatible blood type, and that's all that matters. That's all that seems to matter in terms of the immunologic outcome.
Okay. If there was metastasis to a lymph node and that was treated with radiation, would you then reconsider that particular patient for transplant at a later time if that was then nicked and gone?
Yeah.
I mean,
I don't know, Rich, if you want to
the challenge with the lymph node positivity is that is a mark. A lymph node isn't a life-threatening organ, right? It's just a sign that this tumor has moved, and it increases the likelihood that the cancer comes back after transplant. Well, how does it come back after transplant? They took the whole thing out. Well, the lymph node suggests that there's maybe cancer cells swimming around and that it will come back and land in the new liver. With that being said, if someone's years out from this, I think we would entertain it, right? I mean, I'm never so dogmatic to say no, never. There are some cases that's the case, but a lymph node, it could be entertained, but it would have to be a very exceptional case. And in some ways you say, well, look, if you've done so well, you know, why do you even need a transplant in the first place? You know, maybe you're a
Right.
unique patient who's just done well with treatment, and leave it at that, because it's not the typical scenario.
Great.
Yeah.
Thank you so very much. I know that we're a little over time, so I want to respect your time. But thank you for the presentation today, sharing about the transplant protocol at UCLA. We really appreciate it. And thank you to everyone who was here watching and asking questions.
Thank you so much. Have a
Feel
good
free to
day.
email us. We'll be happy to take emails.
Thank you.
Thank
Bye-bye.
you, everybody.